All right, well, we'll get started and see, what we need to take care of today. So I'll just, I'll start off. Most of you know, I know everyone. I'm Tricia Spears. I'm with the Reach. So I guess first, thank you. Let's see. Rich was at the Restorative Justice Conference. Crystal, I don't know if Crystal, I don't think you've got to come or not. But anybody that attended the Restorative Justice Conference, thank you for attending. And we had 120 some people registered for it. And it was a great 2 days of just sharing all of the practices of restorative justice and finding ways for healing and moving forward. There were CEUs available for LPCs, for PRSS, for attorneys. And then we also had law enforcement there that they were not able to receive CEUs, but so we had a large variety of people there. So it was a great first in-person conference, and I was worn out. I was exhausted. I was part of the planning committee, and so they kind of designated me as the official picture taker. So I was running around campus and going to every single session to take pictures. So I think I got 5 miles in on my first day of just walking on campus. And I was like, and then you're gonna make me sleep in a dorm. That wasn't good. But the rest of it went great. And the planning committee, we're gonna meet again next week to debrief and just figure out, what worked, what didn't work, and start making plans for next year. So there's that. And then our executive director, Bev Sharp, has spent Monday and Tuesday at the White House. So she is fighting the good fight for West Virginia and sharing our stories and our information. So hopefully good things will come out of that meeting. And I don't know, let's see, big things are happening. I'm excited for all of us. That's really all I've got. There's no chair for this council. So if anybody on here would like to step up and be chair, let me know. I would be happy to work with you on that. We are offering trauma-informed care trainings. Those are free trainings. They are geared towards the criminal justice system. So anybody that you can think of, law enforcement, attorneys, public defender's office, any of your specific offices or agencies that you work for. If anybody's interested in having one of those trainings, please reach out to me. I put my information in the chat. Again, they're free, so you just let me know and we will schedule that.
What kind of
It's trauma-informed care.
Okay, thank you.
Yeah. So it is technically it's supposed to be a 6-hour training, but we can probably, make it down to 4 if need be. So it is a pretty long training. So, but we can talk about either doing it Zoom or in person. And the only other thing, is the First Step documentary. If you guys want to have it in, if anybody's local and wants to have it in this area, again, let me know and we can discuss, what we need, as far as a venue and, who we want to invite and then have on the panel afterwards. So we can definitely talk about doing that free screening of that documentary. So that's all I have from the Reach and Reentry Councils. Does anyone have any announcements or anything going on before we let Jeremy decide if he's looking around to see who's here and who he's already talked to? Anybody have anything going on that they want to share? Danica, thank you for being on the Canal Council a couple of weeks ago. That was pretty heated.
Well, we've got the West Virginia CIT Summit in July, at the end of July.
Yeah.
That's a couple days there. And it looks like at the end of August, if anybody's down in Princeton, it looks like there's gonna be some different things going on down there too. There's the event that I'm going to is called Save a Life. And then there's a couple of other events going on that we're gonna be sending information to, for them to be able to hand out, but we can't get, schedules are conflicting as far as somebody being there in person. And I know that's a couple months away, but
Well, if you have flyers and you want me to share them out, I will do that. So
mm,
send them to me. Anyone else have anything going on? Anything exciting? Any community events going on? No, no. All right. Well, Jeremy Dixon is our guest speaker today. Who has not heard Jeremy speak? Doesn't know about his program? Carol? Right. So, Jeremy, the floor is yours. I will give you a share screen and you can decide how you want to.
Sounds good to me. Thanks.
All right. Your
Yeah,
co-host.
so I know, oh, go ahead. Okay. I know I've talked to some of you in here before, but I will I definitely go over some of the stuff and some of the stuff we've been doing about traumatic brain injuries, particularly in the criminal justice system and reentry and substance use. So I think it's kind of interesting to kind of see what we've been doing and kind of see how brain injuries obviously affect that. Let me find my right button here. I have too many windows open. That's not good. Okay. Everybody see that okay? Okay. And I will kind of bounce through some of this stuff pretty quickly. Does everyone see that, or is it the presenter mode? You can see everything good?
Yeah, it looks like you're in presenter mode.
All right. Oh no. Sorry, my other screen's up too, so it's a whole thing. All right. So sorry. First time using Zoom today, obviously.
Oh, you had it and then it disappeared.
Yeah, it keeps coming up on my other screen. All right, sorry, we're gonna leave it there because I'm gonna go crazy. There we go. How's that? Is that better? All right. So yeah, well, I'm Jeremy. I'm from the Traumatic Brain Injury Program at WVU Center for Excellence in Disabilities. So yeah, we're gonna kind of go over kind of some information we've been doing. So this is the nice map of your brain. I'm not going to kind of go over too many details, but I do want to go over that frontal lobe and how much it does control. You can kind of look over some of that stuff, but it is the largest lobe of the brain, and due to its position and size, it is also the most commonly injured lobe of the brain. So you can kind of see some of the stuff that it does damage. With you are damaged that area, how much it's going to affect. So your personality, your emotional control, planning, judgment, decision making, a lot of those personality differences are going to, obviously you guys will probably see a lot of, and kind of I want to go over some of how prevalent they are in these populations. So a TBI, what is it? It's a disruption in the normal brain function. We in West Virginia we classify a TBI as usually due to an external force, so a bump, blow, or jolt to the head. But we also include anoxic brain injuries only due to near drowning. That's kind of the legislative definition that we have to go off of from this we are a state-funded program, so we have to utilize the state definition. So essentially, an overdose would not technically classify, or stroke wouldn't really classify as a quote-unquote traumatic brain injury. Three different severities. A concussion. I'm sure everyone's heard of a concussion. That is considered a traumatic brain injury. And then when you get to more of that moderate to severe levels of TBI, that's going to be usually indicative of some sort of loss of consciousness. Signs and symptoms. There's a lot of signs and symptoms. Like say, TBIs, brain injuries, excuse me, or like a snowflake, right? Everyone's a little bit different than the other. And if you had more than one, the first one's probably going to be a lot different than the second one, and the third one. But the biggest one we kind of focus on, is that behavioral and emotional side of things, especially in the reentry and substance use populations. So elevated depression, anxiety levels, personality changes, social skills issues, mood swings, aggression. Even if you look from the left side of the screen, the cognition piece is kind of how a person thinks. So attention and concentration is going to be in there. Your memory, problem solving skills are all going to be affected a lot from the brain injury. A lot of different causes. We like to highlight a lot of the ones in West Virginia specifically. A third of them come from motor vehicle accidents. Falls is 27%. Which I do need to update. We just did our new social needs assessment, so those numbers do change a little bit. Motor vehicle accidents is still the highest here in the state of West Virginia. Nationally speaking, falls is actually number 1. So it's kind of interesting to kind of see the difference between that. And I'll get into more specific details, especially when it relates to substance use in a few slides. But biggest ones to kind of focus on, I think, in the slides at bottom right corner, that history of a traumatic brain injury, you're 3 times more likely to have a second brain injury. And you're 8 times more likely to have a third brain injury after you've already had 2, right? So that's a big piece whenever we talk about repetitive, even though a lot of people say like I just have a concussion, or I just have a that's not, I don't like whenever we make light of those just a concussion conversation, because they do affect you in a lot of different ways. And the more you have, obviously further down the line, it's going to affect you a little bit more. So substance use and brain injury, between 70-80% of patients with TBI are discharged with a prescription from an opioid. A lot of times these come from a lot of different, orthopedic related injuries too, especially if it's a traumatic issue. When we're talking about a car accident, for example, if there's like a tibia fracture or something, that's probably going to get blunt of the treatment whenever you go into that emergency setting. So a lot of times those are going to be the main priority, and due to a pain levels of something like a tibia fracture, you're probably going to get prescribed some sort of an opiate. A lot of times that traumatic brain injury is not really the biggest thing on the not necessarily the person's mind, but obviously the provider's mind as well. So that those are a high rate of a discharge plan. Another big thing here, people with traumatic brain injury are also 11 times more likely to die of an overdose than those in the non-brain injured population. Pretty massive number. I used to be an athletic trainer. I used to have I had 2 former athletes. Pretty sure they had some concussions back in their, high school athletic days. Self-medication is a big part of dealing with the TBI, especially if you can't sleep at night and the only thing that really gives you relief is some sort of a substance. So that kind of snowballs, years down, as years go on. I'm sure you all obviously know some of those individuals, and that is a big deal. So we've had a couple of those, that same 2 athletes I'm speaking of, ended up having died due to an overdose and suicide. Substance use and brain injury still. I'm going to kind of talk about this birth cohort just for a minute. Those hospitalized before the age of 6 with their first traumatic brain injury are also 3 times more likely to have a diagnosis of either alcohol or drug dependence by their mid-20s, which is a huge number. And then the same number also is very similar that those hospitalized with the first TBI between 16 and 21 also 3 times more likely to be diagnosed with drug dependence also by their mid-20s. We say mid-20s because that's, that's when your brain development kind of halts. And then that last piece, they're highly likelihood of arrest as well. So we talk about criminal justice and brain injury. Around 60% of the incarcerated population, and the estimated of those individuals have had a brain injury. Have estimated that those about half of them are do become unconscious from the brain injury, which we talked about a little bit earlier. That's usually indicative of some sort of loss of consciousness. So if they do lose consciousness, that in a moderate to severe range, those symptoms are going to be a lot more difficult to manage. So we talk about mental health and mood disorders, especially after brain injury. Roughly, this is a study in 2003, so it's almost a little over 20 years ago, which is I always find it very interesting. These are behavioral health symptoms in prisons in Kentucky. So roughly a third of those individuals had depression without a brain injury. But when you looked at, if they've looked at the orange level, 45% of those individuals had one brain injury, had depression. And then if you look at the gray number on the top, if they've had more than one, it's almost 60% of those individuals had elevated depression levels. And you can kind of see how much almost every one of those numbers essentially double after their second traumatic brain injury. So you can kind of see, I thought that's really interesting, especially in the criminal justice setting. Why it all matters, I mean, there's over 7 million people under supervision, and if you kind of guesstimate that 60% roughly, it's over 3.7 million people are living with a brain injury within the justice system. So it's a very, very high number. And a lot of times after in the reentry world, homelessness is obviously a big factor in that as well. The biggest highlight I want to kind of point out is that middle statistic. Almost 3/4 of those individuals that are homeless. This is a study in Colorado. About 3/4 of them acquired their brain injury prior to becoming unhoused. So we talked about all those different symptoms and everything else before. So you can kind of see how common they are in these demographics and how difficult it would be to manage in a reentry side of things if you had all these motivation, if you're lacking motivation, a lack of executive functioning skills. How much more difficult it will be for someone with a brain injury to kind of go from the criminal justice setting where a lot of decisions are not being made to then when they reenter, and then how many more decisions are going to have to be made day to day while having this brain injury. You can kind of see where, how prevalent and how difficult this would be. So what can we do? We can screen, accommodate, and support those individuals. I'll go over some screening differences, screening things we were doing. Like we talked about, the importance of the screening, a person who is compromised functioning in those frontal areas of the brain, like we talked about that frontal lobe, they adapt less well in new or stressful situations. So reentry has greater problems following through, going to be a lot difficult to go to these different places, go to the report centers or go to their probation officers, whatever it might be. It might look like they're being non-compliant, but a lot of times due to the previous brain injury, it's going to make it more difficult for them to follow through on a lot of these different things that they have and responsibilities that they have to do. So what we do, we have a screening tool we've taken from the Ohio State University. We use their TBI ID method. We really like this tool. It's a structured interview designed to elicit lifetime history of a TBI, and it provides more information than like a yes or no. So I can ask everybody in here if you had a brain injury, yes or no, and some of you probably will say yes. But then when we have this little tool with all these little questions on there, I'm sure more of you would say yes after we've read through all of them. This is the tool. You can kind of read through them. I'll kind of go through them real quick. Hospitalized or treated in an emergency room following an injury to your head or neck. Think about any childhood injuries you remember or you were told about. So this goes into like a lower, more childhood injury. So like even if you were a kid or under 5 or 6 years old, you don't remember those days usually. but you could have been told about those. So it just elicits that little time in your life. Injury, head or neck in a car accident or crashing some other moving vehicle like a bicycle, motorcycle, or ATV. Fall or being hit by something, falling from a bike or horse, rollerblading, ice, falling on ice, being hit by a rock. Have you ever injured your head or neck in playing sports or in the playground? So a lot of people have athletic injuries or had concussions through playing soccer or football or wrestling or whatever it might be. Very common. Injured your head or neck in a fight or from being hit by someone or being shaken violently. Have you ever been shot in the head? Those are even something for domestic violence survivors as well. So that's another big demographic of brain injuries. And in your lifetime, have you ever been nearby an explosion or blast occurred? If you've ever served in the military, think about any combat or training related incident. So you can kind of see how many different, it's 5 questions, but it's a very dense 5 questions, right? But it does kind of trigger memory for some folks. So what we've been able to do, we've been able to implement this screener into a few different substance use facilities. And we're actually getting ready to start one on the more reentry side as well, more in the southern part of the state. So we've implemented at Recovery Point. So every person that in all 4 facilities that do have an intake done at Recovery Point is getting screened. So what I can kind of show you those numbers. We started in February 23 in 1 clinic. So if you look in February, there was 25 individuals that got screened, 19 were positive for a brain injury within those 25 individuals. So then immediately after that, you can see in March, those numbers kind of climb. So they've implemented it after that in all 4 of their facilities. And you can kind of see the total number. We have some more updated numbers. I can probably put in there, update this slide a little bit. But you can see 361 positive brain injury screenings out of over 603 individuals that were screened. So it's about a 60%, 59 to 60% positive rate. Pretty high. Also with them, we've done a little study we're doing with them currently as well. So they're collecting some data for us through their ASAM intakes. So we've been able to kind of look through a lot of that information. So I think it's really interesting because I know we talked about how falls and motor vehicle accidents are the top 2 in West Virginia, but in this demographic, motor vehicle is still number 1, but the number 2 highest count is violence. So that's going to be the highest one, and falls isn't until looks like about number 4 after sports. I always thought that was a really interesting slide, just the difference in the demographic of individuals, how much it kind of changes the cause. You can see here substance use history, if they've ever used it, and they kind of see how much they've used. And if you look at number 1, 2, 3, 4, 5, prescription opioids, remember that study at the beginning, it was 70 to 80%, and it's kind of right in the middle. 75% of those individuals have utilized those substances. We talked about mood disorders and mental health, identified triggers to substance use, and the top one is difficulty dealing with feelings, which is, right along the lines with that study we kind of looked at over before. And again, mental health is right there on number 4 as well. Negative implications, you can look at those as well. You can see drug and alcohol use. There's legal implications is number 1, with relationships, and mental health, again, kind of squeaks in there as well. So there's a lot of types of symptoms you can see that we usually see a lot. Can everyone see this okay? Okay. Memory, attention, impulse control, organizational issues. We ended up developing this cool little slider tool. So if you do screen positive, you can see this little slider card. So in the front, you can see there, if you look on the right-hand side, those list of symptoms are on the right. And in the little text box and little window, I can show you what it looks like after I'm done sharing my screen. If you look on the top right, if you have memory issues, I forget what I did yesterday, I forget what I read, that type of thing. And then if you flip the card over on the back, excuse me, then on the top right-hand corner, that'll be the accommodations for that. So I can show you that how it goes. So who we are, like I mentioned, we're the lead agency for coordination of services for individuals with a brain injury. We're a free program to anybody in the state that the two eligibility requirements, they have to live in the state of West Virginia and they have to provide that medical documentation of the traumatic brain injury. So hence that screening tool could be helpful in kind of navigating that as well. It's not a diagnostic tool, but we could hopefully get you in the right hands of a provider that can give you that diagnosis. Once you become part of the program, we have to do some release of information so we can find those documentation. And then we'll give the individual an ID card that tells them that they're a person with a brain injury, how they can best be communicated with, and they can actually customize this tool or customize the card to their specific symptoms. So if there is a run-in in the community, police officer, whatever it might be, they can at least have that card handy to kind of, advocate for themselves. We have 5 social workers, they're our resource coordinators. There we have 5 statewide. You can kind of see on the map there how they're split up. And what they'll do after they become part of the program, they'll do a social needs assessment in that particular region with that social worker, and then they're going to create a plan to assess any of those immediate needs, improve quality of life, promote independence, any type of thing, that, like I mentioned before, brain injuries are so different, so each person needs something a little bit different. And we have a great social work team that's really good at really finding out what they need. We pay for neuropsychological assessments as well that'll help identify any strengths or weaknesses, for the individual. And the biggest, well, in my opinion, the best thing that comes from those is, that list of recommendations at the end of those evaluations, and they're really, really good to help navigate after that. We have a financial assistance program. It's called Funds for You. It's funded through the Bureau for Behavioral Health. We can provide access to that funding source. It's about $2,300 every year. There's different caps and different categories. They can go to a variety of different things. Just an example, someone from Recovery Point recently was able to utilize that funding to get a down payment for their apartment, after they graduated from Recovery Point. So that's a big part of the program. You kind of see on the screen a lot of different things that, that we can do with that. I'll buzz through this. This is more of a concussion thing for school systems. We have obviously do technical assistance, trainings, that type of thing throughout the state.
Okay, I don't know about anybody else, but I can't see the screen that you're on. I'm still on the one that says table 3 and table 4.
Okay, so sorry. All right, I was done, so it's okay. We're good. I was just going to go over this big brain. Yeah, we have this giant brain. We take places as well. So, so sorry you missed all that. My apologies. This was the other stuff. We talked about the brain injury ID card and some different symptoms that they can include. Yeah, my apologies. I didn't know it shut off. I'm sorry.
Is it possible to get a copy of your PowerPoint?
Yeah, of course, I can send it out. This is that little slider card I mentioned, and probably didn't see it, obviously. But it has different like memories on the top here, and in the little text box it says I have, I forget my appointments, I forget what I did yesterday. And then if you flip the card over, memory is still blacked out. And in the middle, there's different accommodations that they can be placed in person. So we like to do those, especially in substance use facilities. The meeting's going to look a little different if they have a hard time in a big meeting space with a lot of people with bright lights. That could potentially affect the meeting and how effective that could be. So having something like this, if they have light sensitivity, they can at least refer to it and at least accommodate them in real time. However, they're all going to look a little bit different, but yeah, no one's going to have every symptom, but if there's a few little things that they can provide, that's going to be the biggest difference. But thanks. So sorry that messed up. My apologies.
Hey, Jeremy, are you ready for some questions now?
Sure, Rich.
All right. I just have one, and I think we have talked about it, but I just need you to refresh my memory. And so I don't know how it is in Kaylee's area, and Kaylee may be asking the same question. I don't know. but the neuropsych evaluations, historically, we found it very difficult to find providers to do those for our consumers. But I think you and I talked about that you all didn't have that issue, that your issue was more of getting folks to show up for the evaluations. Did you
Yeah,
say that? Did I dream that
it's
or
funny you said that. We just had our team meeting just a little bit ago, and we have a list of people that we use for neuropsychs. A lot of times it's not an issue to get them scheduled, but it's from folks with brain injury. Sometimes the follow through is just not quite there, so they haven't showed up. We've actually hit more our neuropsych line, and we hit almost our cap this year, which we've never even came close to in the past. But we're actually looking up. We actually have a list. Someone just sent us. I didn't get it, but I can send you a link. There's a list of different neuropsych. We're going to try to reach out to the Bureau for Behavioral Health to see if there's a list of those neuropsych physicians, but we try to get one in each region. So there's one in the Eastern Panhandle, obviously Morgantown, and kind of down 79 all the way to Charleston. But
we
I
had a
can,
list at one point. I think it might have been on your website, or you might have provided
Yeah.
it to me before. But if you could send an updated list, that'd be great. Again, Keely looks like she might have something to say or a question and something to add.
I had somebody a couple years ago that we needed a neuropsych for. We actually found a vendor. They're out of Pittsburgh. That was kind of the closest for us here in Brooke and Hancock County, and it was Elisa Young. I don't know if you. I know she's not West Virginia, but Pittsburgh was kind of the closest we could get somebody to. So that's who we used.
Did they had to go to Pittsburgh, Kaylee, or did the lady come to your area?
We sent them to Pittsburgh. Yeah, so we just used like a cab. And if we set up the transportation, that helps ensure the person gets there a little bit more, because there's a little bit more of support and other people that can kind of help take responsibility getting them there.
Yeah, that makes sense. I wish we could do. That's a good idea to have that. That's really good. And I mean, like, we get 40 every year, and we've historically haven't got close to that, but now we're actually already have 5 for next fiscal year. Our fiscal year ends here in a couple of days, but we already have, I guess Carrie told me this morning, we have 5 already on the list for next fiscal year already. So that's a good thing.
I know that certain transportations can be covered by Medicaid when it comes to going to appointments, and some of those transportations have occurred outside of the state in Pennsylvania and Cincinnati and different places, depending on where the person needs to go for a specialty. So you may want to look into that also with you all with dealing with people that are in the Morgantown area, especially because Pittsburgh is right there. So
Yeah.
you may want to consider that.
Okay, yeah, that's great. Thank you. Any other questions? I'll put our website in the chat. There's an orange button in kind of on that main page. It says get services from the CED. If you just go on there and you can kind of fill it out, and it's pretty easy to make a referral. And then you usually get a call within a couple days from our intake coordinator. Kind of set up an intake. Yeah, thank you.
Thank you, Jeremy. Have any questions for Jeremy or anything they want to share or anything going on? One last ask. Does anyone want to present next month? No. All right. Well, I will give you back some time for your day. So, oh,
I put the presentation, the
Yeah.
PDF form in the chat. So if anybody wants to say.
right.
That might be the longer one. That might be a longer one, but there's more information in that one. The other one, this one's a little shorter, but
Let me, I will download that and send it out then. So, all right. Well, if anyone needs anything, just email me and let me know. Otherwise, I will see you all either this afternoon at the next council meeting, or I will see you next month. Thank you. Bye.